So I think really the focus of this discussion is to think about content that we can put out there that really speaks to the idea of identification of high-risk patients. And I know that there's a lot of genetics focus on this definition, but I think it would probably be of value, given the breadth and depth of who is coming to the site, to also put on some clinical characteristics of high-risk disease, particularly clues that patients may present with that may be there before we get the genetics and the other information back, that give us a sense that this patient may behave differently than the average patient with myeloma. So do you all want to have sort of a little bit of an idea in terms of topics or things to be covered in this session? So maybe we start off with that intersection between genetics and clinical characteristics that we as clinicians use to identify high-risk patients.
Well, maybe from the clinical point of view, the functional high risk, those patients treated with the first line of therapy. In principle, some patients do not present any high-risk cytogenetic abnormalities, at least known high-risk cytogenetic abnormalities. And when they progress within the first year, even within the first 2 years, definitely these patients are functional high risk. And I think that in a retrospective way, it would be good to try to analyze these patients, the samples of these patients from the molecular point of view, in order to understand why these patients present definitely a shorter progression-free survival, or the durability of the response is shorter than expected.
When we talk about high risk, I think it's then going to be useful to distinguish pre at diagnosis and these post hoc variables where, you know, after the fact, you've demonstrated the biology is drug resistant. That's very different in terms of the pre-treatment variables that we often use in making decisions up front about the number of drugs, the generation of drugs that we use versus patients. You know what I mean? Pre-treatment biology, post-hoc therapy, that's all.
I would just like to build on that, Sagar, by emphasizing this whole construct around EMD and when it emerges and what it looks like. And obviously EMD after CD38 failure versus de novo being quite distinct in terms of my own experience with that, but also some of the data supporting that. And I think that Mohammed's put a nice comment in the chat about primary refractory patients to triplet or quadruplet therapy, which I think is a rare, thank goodness, but important subgroup. I think what we've learned from determination is the incredible complexity of the genetics, though, and how we sort of currently sort of silo high risk. You know, we try and define it, but increasingly we realize that, you know, for example, as you know only too well, you know, our 414s by our classification determination do particularly well with transplant. Conversely, however, the 17Ps don't kind of sit anywhere for both arms particularly well. So I think just this idea of separating high risk and understanding this kind of one size fits all is a tricky place to go with high risk. It needs to be much more functional, to Mary V's point, and integrating genetics as well as clinicopathologic features.
Yes. So one should distinguish different categories. Category one is clinical features and lab features at the beginning, and then response to therapy. So this is what you want to distinguish between the baseline clinical features, which indicate high risk, and then when you start treatment, of course, response to treatment is an important risk factor, no question. And the time to response may be an important risk factor as well. But that is there are different studies providing different results. But yeah.
So Heinz, I want to ask you a little bit more about the time to response, because I think Shaji or others have published that the time to response, for instance, for 1114 may be slower than it is for other subsets. And that doesn't necessarily mean that they're going to do worse. It just means the kinetics may be different. And that in and of itself is not the reason, but it's part of why I'm hesitant to not establish timelines for when we evaluate MRD status, because there may or may not be differences between somebody who achieves MRD negativity at cycle 4 versus cycle 8 or 1 year. Those may not be the same. I'm just curious your thoughts about that.
Completely agree, and that the time to response probably depends also on the type of treatment the patient is exposed to, because with conventional therapy, it seems to be patients have a favorable outcome if they don't respond too fast, but that may be completely different with high dose therapy and so on. I'm not, it's getting a little bit, let's say, one would need to break it down, and the evidence is not strong enough to use this as a criterion which is taken up by the community, in my opinion, because we have these diverging results. We did a study with conventional therapy, with carfilzomib, KRD, and patients who responded later had a better outcome at those early responders. But that may be different with when you use, I think, quadruplets or whatever. So that is probably, maybe we could keep that for further discussions and try to be quite, let's say, simple and straightforward. So we have the clinical parameters at presentation, we have the cytogenetic parameters at presentation, and then we followed our patients, and then during the course of disease, we can decide about primary refractory, rapid relapse, probably. That is simple and easy, and easy to be, let's say, taken up by the community.
Yeah, maybe the biology of the disease is also different, but it's true that in all the series of patients, there is approximately 20% of the patients in which, well, the quality of the response is not very deep, and the majority of the patients are sometimes in PR or VGPR, and the outcome is excellent, and the progression-free survival is very long. Maybe it would be good to incorporate into the evaluation the bone marrow microenvironment and the immune system. And this can potentially explain why some patients, in spite of not achieving minimal residual disease negative or optimal response, they have good outcomes. And I think that this is in line with a question that is planning here, Mohammed, in the chat about the high risk. What about being MRD positive after 1 year of maintenance?
I completely agree, Marie-V, and you and your group and Bruno have shown that patients with MGUS-like phenotype,
Exactly,
they don't achieve a complete response or MRD negativity, but still they have a very good outcome. And of course, the composition of the bone marrow environment at start of therapy is important, but that is probably not helpful at the time for people working in the community.
Yeah, no, it's true. The main challenge is how to implement this, not only in the clinical practice, but even in an academic center. Well, sometimes it is difficult, and it's true that, but well, from the research point of view, I think that this can be useful in order to identify or in order to explain why patients not achieving the optimal response present good outcomes. And this is in line with the comment exposed by Mohammed. If we have a patient that well, has been treated with RVD transplant lane maintenance, and the patient is in MRD positive 1 year after starting maintenance, of course, we have to assume that the patient was positive before starting maintenance. Do we have to do any change because we can consider that the response is suboptimal or something like that? And I don't know.
So if you can figure out by immunophenotyping that you have this specific subgroup of MGUS-like phenotype, then probably you don't need to urge your patient to achieve complete response or MRD negativity. But I think that is not something which is standardized, and it's not common practice in all the centers. So maybe that is a little bit probably too complex. You can mention that would be an additional option, but for simple and easy recommendations, it's probably nothing which is which should be recommended to be followed in all institutions.
I'm going to throw out a controversial question here, and that is about, so we have clearly defined by the IMWG staging 414, 1416, 17p deletion as being identifying a group of patients that, while may not be 100% predictive, certainly is predictive for poorer outcomes compared to the standard hyperdiploid patient. I'm going to throw out 1Q and get people's opinions on the importance of 1Q, how many copies, what it means in isolation versus with something else, and then other genetic markers that people want to throw out there that perhaps are not validated or accepted, but they consider to be suspicious for high-risk disease.
Yeah, I would chime in first with saying 1Q for sure, Saga. I would agree with you. I think obviously defining it is critical, and it's bedfellows, right? That's kind of what we're sort of gleaning again from deeper dives and determination. The other group that's interesting, I don't know if you've seen this, 1114 is more complicated. But I mean, the clue is that, of course, it's overexpressed in PCL, right? Or, you know, it's highly represented in PCL. My own clinical experience with 1114 has been yes and no kind of thing in terms of its behavior. Sometimes some really aggressive behavior from 1114. And I just wondered if there's data to support that beyond obviously the PCL observation.
Yeah, so I'll go, and I know many others want to make a comment too, so I don't want to shorten the discussion, but certainly on the 1Q, I'm going to say that I don't think isolated 3 copies means anything. We've looked back at our RVD 1000 series, and there's no difference in PFS between 3 copies without anything else. So I think 1Q to me is still a bit of a grab bag. I almost think about it as you acquire extra copies, the longer you have myeloma. And so it may be reflective of time from transformation as opposed to an independent predictive factor. And then let me make the 1114 comment, and then I'll let other people react to what I'm sure is going to create discussion. The second is the 1114. And when we looked at PFS for 1114 versus non-1114 in our RVD 1000 series, the PFS for 1114 is actually shorter. The OS is not. So I don't think it necessarily has an implication on long-term outcomes, particularly if they have access to venetoclax. But what we're finding is that the 1114 is actually more B-cell-like and is highly sensitive to transplant. So when you have an access issue with, for instance, African Americans not getting transplanted as often, that's why the 1114 African Americans do worse than the 1114 Caucasians, because it turns out they're actually more sensitive to venetoclax than the Caucasians are. And so I think 1114, there are some questions about how to best treat it. So I'll stop there.
Yeah, no, I agree. And well, sorry, Morie, go ahead.
No, I was just going to say that regarding the 1Q, I really like your second revision of ISS where 414 and 17 get a point, but the 1Q gets a half a point. So it's higher risk, but it doesn't rise to the level of the other genetic abnormalities. I mean, you had a lot of people in there, and that 0.5, I like that graded scaling of the relative genetic risks.
I was going to say, Sagar, that we have in our Spanish myeloma group the same experience with plus 1Q, or in principle, they don't add any prognostic value. And by contrast, I think that, for example, if we wanted to add ISS3 plus amplification of 1Q, the outcome is extremely poor. And I think that it is also important to emphasize this double hit subgroup of patients, although personally, I think that there are multiple definitions of double hit. I like very much that proposed by the COMPASS study, ISS3 plus either inactivation, biallelic inactivation of p53 or amplification of 1Q, because it is demonstrated in over 1,900 patients how the outcome is very poor. I would like also to incorporate something, and I don't know if you do in routine, mutations of a P53 by next generation sequencing. In Spain, well, from the classical point of view, we did fish analysis, of course, in plasma cell, in selected plasma cells, but now we are also doing P53 by next generation sequencing in order to see if there is inactivation of P53, because it is quite simple and maybe the information can be very useful from the prognostic point of view.
So I think another question which pops up is, should we talk about the cutoff values, the clonal load of deletion 17p or not? Because I think we get positive or negative results from all laboratories, but probably the laboratories use different cutoff values for rating a patient positive or negative. But I think, in my opinion, I think we shouldn't go too much into details regarding these cutoff levels, because it is presently impossible to harmonize all the different laboratories to just follow one recommendation. Particularly the Abe-Louisseau recommendation to use 50% clonal load of deletion 17p. I think that is unrealistic to implement that all over the globe at this point of time.
In our experience, well, the higher the percentage of plasma cells with deletion 17p, the poor prognosis. But if 10-20% of the plasma cells do present a deletion 17p, we see the poor prognosis in our CDS.
Mm-hmm.
Yeah, I do think it's interesting because the analogy I always use is that 17p is like being pregnant. Either you are or you're not. And while the percentage may impact an immediate short-term endpoint, everything you do is going to enrich the percentage of cells that have more 17p. And so we take the tack that you want to hit it pretty hard, even if you have low clonal burden, to suppress the clonal burden for as long as you can, because eventually that's going to change. And, if you undertreat a 17p because it only has 20% clonal cells as opposed to 50 or more, the next time you see it, it's going to have 50 or more. So under treatment may not necessarily be a good thing in that sense.
Yeah, I completely agree, Sagar. I think 17p is the one thing that we just face with increasing concern. I guess the only question I would have as we build this, Sagar, this section, do you want to talk a little bit about therapeutics? I mean, obviously, what we learn from not to perseverate on determination, but what we learn from determination, high risk, targeting MRD, getting to MRD matters, because that can shut down, perhaps, at least based on early follow-up, some of the adverse features. But do we also want to talk about some of the newer strategies for targeting high-risk disease, or where do you see that going? And obviously that pivots back to the issue of access, right? And what people have and what people don't have. And so I'm very sensitive to the point that in high risk, targeting stemness, high dose therapy makes sense, particularly in healthcare jurisdictions where access to novel therapies may be more limited. But I think then as we think about newer approaches to high risk, I just would love a flavor from everyone of what they think, because obviously there's a signal from teclistamab that it's very active in high risk, right? Is that fair to say?
I mean, I at least in my experience, the response rate may be good. The question is about durability.
Yeah, I hear you. Yeah,
and I don't know that and when you're in 6 prior lines of therapy, everybody's high risk, right?
No, I just think it's something that frames therapeutic options that are practical in whichever healthcare jurisdiction one sits. I mean, I personally, I still, I firmly believe there are high risk strategies that we have. Obviously, quadruplets. I do think there is a role recognizing the tolerability challenges, but nonetheless, in my practice, I've used it successfully, selinexor, and only in combination, obviously, and other strategies targeting high-risk disease, in particular the immune therapies and importantly CAR-T. But I take your point absolutely, Sagar. Durability of disease control is key. But I guess beyond that, I mean, I think, right, Sagar, for iberdomide and mezigdomide in the experimental setting, we see activity in high risk, but it's probably too early to comment on that. What do you think?
I would agree. I think right now it's the data sets I don't think are large enough necessarily to do that, but
Right.
Certainly they may partner nicely with
Exactly, with other
with
strategies to overcome it. And then obviously carfilzomib, and the usual suspects for overcoming 17p.
There seem to be some data that patients with extramedullary manifestations might benefit from mezigdomide, so that could be a specific option for these patients.
Yeah, and speaking, with Heinz's and Marie-Victoria's being partners in this, obviously very available in Europe, melflufen and EMD for sure.
Yeah.
I mean, I think the other area that, if you want to talk about therapeutic approaches, is the use of triplet maintenance for the high risk in the post-transplant setting. And our group, as you all know, has used VRD for a long time, but I think the Forte data, at least in my mind, has really solidified the benefit of a KRD consolidation approach in the post-transplant setting, particularly in the high risk, Marie-V, as you described, as the double hit or the high risk. I think they very nicely showed that there clearly was benefit for 2 over single agent lenalidomide in that context. And that's probably the closest to randomized data we have, at least as of now, to speak to that.
Yeah, it's true. And Sagar, are you using right now in the high risk as maintenance carfilzomib every 15 days plus lenalidomide in routine?
No, we're giving it weekly. So 1, 8, and 15 along with len. And for the first year, we're still giving dex.
Okay, and carfilzomib until progression disease?
3 years. And after 3 years, we then go to single agent len.
Yeah, no, because I think that this is interesting, and definitely you are, well, giving a more potent proteasome inhibitor. What is important in the high risk, the problem from my point of view is to maintain the patients under carfilzomib, of course, once per week, every 15 days for 3 years. So this is for me the challenging situation.
Yeah, I'm not pretending it's easy, but
and just another question: do you monitor minimal residual disease? Because maybe once the patient is in MRD negative, it would be possible to stop, I don't know, at least carfilzomib and to maintain lenalidomide, just in order to, well, to be more, to have a regime more convenient.
Yeah. So we are checking MRD annually on this. I don't know that I have that data in front of me. Ajay probably has that data. I will say, and I don't think we have this data for ASH, but we might for ASCO. We had another trial looking at CAR-POM maintenance for high-risk patients. And these were all, we knew they all got a good triplet induction transplant. And then if they were high-risk, CAR-POM is what we did. I think we've got a total of 30 or 35 patients. The data there is phenomenal.